We got to stop seeing obesity as just a aesthetic inconvenience, but actually a major health threat. If you have 20 pounds of fat in your body, you have probably 2 pounds of excess visceral fat, and that visceral fat acts like a tumor. And so it's not surprising to find out it responds very much like other types of tumors do to fasting. If you go to a medical doctor, they're going to tell you, take these drugs. They will have side effects, chronic cough, fatigue, impotence, premature death, but that's the best you can do. And we promise you, if you take the drugs exactly like they're prescribed, you'll never get well. You'll be on these medications forever. Nobody ever gets better. It's because nobody's dealing with the actual cause of disease. Well, we've got some data now, which is really exciting, on a study we did with our colleagues from the Mayo Clinic, which was in treating high blood pressure with fasting. And we enrolled 29 patients with hypertensive problems. They underwent fasting, and all 29 experienced significant reductions in blood pressure. In fact, 28 out of the 29 were completely medication-free at 6-week follow-up. One was on half-dose medication. The body's ability to heal itself is absolutely fascinating, and the time you get to see it best is in fasting.
When it comes to water-only fasting, what makes this such a powerful tool for weight loss and beyond?
Well, one of the great benefits of water-only fasting is it preferentially mobilizes something called visceral fat. And visceral fat is the type of fat that tends to accumulate around your belly and in your organs. And it's associated with the production of inflammation markers that cause heart disease, cancer, diabetes, autoimmune disease, a whole host of common disruptions. And so any kind of weight loss program will help mobilize adipose tissue and to some degree mobilize visceral fat. But fasting does this more effectively, more efficiently than other methods that we've evaluated. And we think that that's one of the reasons why we see such profound changes in many of these diseases of dietary excess when people undergo water-only fasting.
So just so I understand the nuance here correctly, if somebody were to use a more traditional method for losing weight and their body composition did come down and they lost body fat, they would lose less visceral fat compared to water-only fasting as a percentage.
In a given time. So if you think about this, about 10% on average of people's fat is visceral fat. And so if you go on a fast and you lose, say, 10% of your body weight, you might assume that you'd lose 10% of your fat, but that's not the case. A typical person that goes on a 2-week fast that loses 10% of their body weight will lose 20% of their fat and as much as 40 or 50% of their visceral fat. And so there's a disproportionate mobilization. You might say, why would that be? Well, just like when you go on a fast, you might lose 10% of your weight. You don't lose 10% of your breast tumor. You might lose 50% or 100% of the tumor because the body has a method of preferentially mobilizing tissue in inverse proportion to the body's needs. And so visceral fat shouldn't be there in quantity. When you think about it, somebody that's overweight, we know that there are increased risks, for example, of heart disease, cancer, diabetes, even COVID-19. One of the big risk factors was obesity. The fatter you are, the more visceral fat you are, the more likely you're going to die from any infectious disease, including, it turned out to be COVID. And so we got to stop seeing obesity as just a aesthetic, inconvenience, but actually a major health threat. If you have 20 pounds of fat in your body, you have probably 2 pounds of excess visceral fat, and that visceral fat acts like a tumor. And if you went up to somebody and said, look, you have a 2-pound abdominal tumor, they wouldn't be surprised to find out that visceral, that tumor was having potentially adverse effects on their health. And so it shouldn't be shocking to us to find out when we have, a multi-pound visceral fat, essentially tumor, that's hypermetabolic, hyperplastic, that's producing inflammatory products, that process of being overweight is actually a major health threat.
The piece I just want to make sure we really tease out, though, is the fact that if somebody loses that weight in a different method, say going low carb, putting some intermittent fasting in, and the time frame is different. Obviously, water fasting, you're going to get your most profound weight loss quickly. But will the percentage of visceral fat, if you lose 20 pounds of fat, however you get there, will you lose the same amount of visceral fat? Or is there something specific about this water fasting that beyond, say, we could use different ways of losing weight, bringing down calories, exercise, some arguably better than others, and there's a lot of controversy on the best way to do that. But if somebody lost 20 pounds of body fat using water only fasting versus a different method, will they lose more of that visceral fat on just water? And if so, why specifically?
It's not quite that simple because remember, there's a bell curve. There's a range in how any individual responds. Some people they can have a lot of fat, but not a lot of visceral fat. Some people they may not even be that overweight, but they're over fat. So we got to keep that in mind, that it's complicated when you look at an individual versus epidemiologically or a larger group. But yes, water fasting preferentially mobilizes the visceral fat. So you might lose 20 pounds, the same 20 pounds, say, diet versus fasting, but it's likely the proportion of visceral fat that's mobilized is going to be higher with water fasting. Eventually, if you eat well enough and exercise and live right, you're going to lose both your fat and your visceral fat. But over a given period of time or over a given amount of weight, it's likely that the proportion of visceral fat is going to be higher. And it's just like if you lose 10 pounds of weight eating, you may not lose a disproportionate amount of your tumor size. Tumors will also break down. What I'm really suggesting here is that visceral fat is acting very much like a tumor. And so it's not surprising to find out it responds very much like other types of tumors do to fasting.
And do you recommend for somebody who right now feels like they're healthy, their regular body weight, is it important to get tested for visceral fat using something like an MRI or DEXA scan? Because
I don't think so. If you're on
it gives us somewhat of an idea of where we're at with the visceral fat, but we can't exactly see what's happening inside around the organs, even if somebody appears to be skinny.
Right. So that's why we use the DEXA scan with special software for the purposes of the study. I don't think for most people, practically, it's that important, because if you're willing to adopt a whole plant food, SOS-free diet, exercise, and get enough rest, both the fat and the visceral fat are going to disseminate and break down. And so I think you're going to achieve your goal, whether you're being monitored or you're not being monitored. If you find that that's a useful motivation factor to drive your behavior, then maybe there's some utility. But it's certainly not, I don't think, an essential requirement for people, so long as they're willing to adopt healthful living habits. But from a research standpoint, we needed to know what happens to people when they fast. And we know that weight comes off and weight comes back on. The weight you lose during fasting includes protein, fat, fiber, glycogen, and the weight you regain during recovery after fasting is protein, fiber, glycogen, but not fat. The fat continued to come down, and preferentially the visceral fat. That's when we think about this. In 2 weeks, a given individual may have lost somewhere between 39 and 55% of their total visceral fat load. So that is clearly much faster and disproportionate to what we see with, say, other types of intervention.
Talk about lean mass and doing the long end of the protocol that you guys do at TrueNorth is 40 days of just water. How much lean mass can somebody lose doing a fast that long? And you talked about they're putting protein back on. I'm assuming you're talking about lean mass. Talk about what happens during fasting and then afterwards, because that would be a big concern for a lot of people who, especially as they're aging and they're losing muscle mass, they don't want to have that happen at an increased rate. So in the end, do they have less lean mass, or does it all come back?
So in this same example that I gave you, where a person fasts for 2 weeks and loses 10% of their total weight, 20% of their total fat, 40% to 50% of their visceral fat, they lose about 6% of their lean mass. But what's interesting is at 6-week follow-up, those people, as a proportion of their overall body, had a higher lean mass than they did at baseline. Now, their overall body is smaller because they've lost a lot of weight, but the percentage of it that's lean mass is actually higher. So they recover the lean tissue, but not the fat. The fat continued to come down.
Talk about long-term effects, some of the long tail of doing, say, a 40-day water fast, because this pivots off what we're talking about here, regaining the lean mass and beyond. But what are some of the benefits people see even 6 months, a year, multiple years down the road after doing a significant fast using water only?
Well, we've got some data now, which is really exciting, on a study we did with our colleagues from the Mayo Clinic, which was in treating high blood pressure with fasting. And we enrolled 29 patients with hypertensive problems. They underwent fasting, and all uh, 29 experienced significant reductions in blood pressure. In fact, 28 out of the 29 were completely medication-free at 6-week follow-up. One was on half-dose medication. And then we followed those people for a year to determine what happened after a year when they were, free living and went back home. And not everybody completely complied with our whole plant food SOS-free diet recommendations. But what 75% of the patients were able to maintain their weight loss, their blood pressure-free, drug-free state. So their normal blood pressure, drug-free state, normal weight loss. 25% of people, 1 in 4, had some trouble with regaining weight, and some of those ended up with blood pressure coming back. Because remember, when you're treating obesity or you're treating high blood pressure, or you're treating diabetes, you're not curing anything. You're managing it. You can lose the weight and keep it off the rest of your life, but you have to keep eating well and exercising. You can normalize your blood sugars, get off the insulin, get off the medication, but you have to continue to do the diet and lifestyle variables. And the same thing's true with patients, for example, we treat with lymphoma. That you can see dramatic results with fasting, but it still requires the diet and lifestyle changes in order to sustain the long-term benefit.
And when we boil all this down and talk about all these different chronic diseases that improve when somebody's doing a water-only fast, we opened up really focusing in on visceral fat. Is that, would you say, would that be the root of all of this? Visceral fat causing inflammation in the body, leading to chronic disease?
So the diet that makes you fat is the diet that gives you visceral fat. And it's the diet that makes you fat that's associated with heart disease, cancer, diabetes, and autoimmune diseases. What's interesting about these different conditions is they're treated as if they're completely separate entities. In fact, you have to go to different doctors just to be evaluated and treated for these different conditions, but they all have one thing in common. They're all associated with the consequences of dietary excess. And we believe that one of the factors is this visceral fat, this tumor-like response of visceral fat. But there's other variables like gut microbiome changes. You have, 5 pounds of bacteria living in your intestinal tract that's there to protect you. If you're on a plant-based diet, you're going to have 1,000 different strains of these organisms working together, providing things like fertilizer, like vitamin K. On the other hand, for example, people on animal-based diets have completely different organisms. And those organisms, these living creatures, are breathing, eating, and defecating inside you. And what they poo in you could be, as I said, fertilizer, or it could be toxic waste like TMA, which becomes trimethylamine oxidase and is associated with cancer and colon cancer and heart disease. Meat eaters, for example, have much higher levels of TMA than plant eaters do. So there's what you stick in your mouth affects which organisms you grow and what those organisms poo in you. So we know that diet does play an important role, and fasting turns out to be really helpful at rebooting that gut microbiome. If you have a computer that's corrupted and you don't know what's screwed up, but just shut the whole thing down, you turn it back on, oftentimes things start working better. You kind of reboot the hard drive. It clears a lot of corruption out. Well, the same thing appears to happen with fasting. You shut everything down. There's a big die-off in microbiome. You put a good plant-based diet into after the fasting, and you grow back the organisms that are designed to keep you healthy. On the other hand, if you're filling yourself with sugar and refined carbohydrates and all these processed foods, you can see where it's going to have a profound effect on that balance. And that may be another one of the mechanisms by which diet and lifestyle play an important role. There are lots of different mechanisms that are at play. Visceral fat, gut microbiome are just a couple examples.
If you're enjoying this episode, take a second and let me know by clicking like and subscribe below. Thank you so much, and now back to the show. Let's really hone in on the microbiome piece here. And we can use any diet to start with when somebody comes to see you, either they're including animal products or not. You mentioned number of species. How much does that change throughout a 40-day water fast? Number of species, I'm assuming we must lose a lot of diversity and also volume. So talk about that. And then you talked about feeding the microbiome with high quality plant foods at the end. Let's talk about that process of rebuilding as well.
Well, the first study that's been done on long-term water fasting's effect on the microbiome was actually done at our facility, along with our colleagues from Washington University. The first paper that's resulted from that original research that we did several years ago has appeared in Lancet preprints, and it talks about inflammatory components that happen like during fasting. And the next paper that's coming out should be looking at specifically the organisms, which type of organisms are growing. But we do know there's some general things, particularly from animal waste studies. There's a big die-off during fasting. There's a big drop in total volume of all species during fasting. The key is after fasting, during that refeeding period, you introduce a health-promoting diet, and that will tend to allow the system to kind of reboot. So that's what the theory is right now, and that seems to match what we experience clinically. In other words, if you treat patients' obvious bowel disease conditions like ulcerative colitis and Crohn's disease, and these clearly bowel-related conditions often improve dramatically after fasting. And part of the postulation is that these microbiotic imbalances tend to normalize after fasting. So it looks like that way clinically. We're hoping to have hard data coming in from these studies where we took stool samples before and then after, and then on follow-up, and doing the really complex analysis of looking at all the different strains. You can imagine when you're trying to identify 1,000 different strains of organisms, how complicated it is from a research standpoint. Very challenging.
One thing I would fear going into, say, 40 days just on water is bringing down a species to level 0 and not having any seeds there to regrow after 40 days just on water. This is a really extreme and unique position to put a human through. Do we know what happens to these species as that die-off's occurring? Are we assuming at this point there's still remnants of the different species that we can feed after and get growth from? What I'm getting at here is just the fact that this is so extreme, and if we're killing everything off to the point of being none of specific species, how do we regrow those?
Because remember, the first of all, we don't know whether it's certainly not a sterile, environment even after 40 days of fasting. But the important thing is the prebiotic program, which is where your primary source of ongoing, creating an environment where the normal organisms can grow. And so there's potentially a huge advantage of getting rid of a lot of the species that may be not normal to the human gut, not health promoting, and that normally that balance is trying to keep in check. Fasting appears to be extremely helpful in helping recalibrate that balance. But the key is going to be the prebiotic source of ongoing environmental support to grow the normal organisms that naturally do that. If you create the right environment, they're there. It's just like all throughout nature. It's not just your gut, it's on your skin, it's in the environment. If you take a human being, for example, and separate them into cells that are human cells versus non-human cells, protozoa, bacteria, viruses, there's more non-human cells making up your body than human cells. And so those organisms don't just completely disappear, but their balance, their ratios clearly are affected, both long-term by the diet and short-term by fasting.
All right. Well, what you're highlighting there is my fear, because they play such an important role and there is so many. If we're killing them off, can we get those back again? And by the sounds of it here, it's not something we're afraid of going through this.
Yeah, we clearly are clinically, because we've been doing this for 40 years. We've had 25,000 patients go through this protocol. And when you look at our outcome data that we're publishing, the clinical outcomes are fabulous. For example, high blood pressure. We have the largest effect size ever shown in treating high blood pressure in humans. 174 consecutive patients with high blood pressure. 174 people lower their pressure enough to eliminate medication. Type 2 diabetes, a significant percentage are able to achieve normal blood sugar levels without medication. Irritable bowel, ulcerative colitis, Crohn's disease. These patients experiencing significant objective short and long-term clinical benefit. It's very likely that what we're going to find in the research that we've done, that we're waiting to get analysis on, that in fact there is a normalization of bacterial flora, because you see the results clinically. As far as hardcore, which species, all of that, that's all brand new. That's not something that we have compelling data on. There's a lot of animal data, but you can't necessarily extrapolate, say, rodent data to human data, because rodents are very different metabolisms. Rodents can fast 4 or 5 days. Humans can fast, up to a year. So, you know what I mean? There's quite a bit of challenges when it comes to try to compare the animal to the human studies.
So again, coming back to this 40-day number, this is on the extreme end. I believe it's 5 days to 40 days, depending on the person.
That's just in our clinic.
Be on that's what I'm saying, for your clinic.
Yeah.
How do you determine if somebody comes to see you, how long between that 5 days and 40 days they're going to need to fast?
So we limit it to 40 days. In the past, people have been fasting people 60 days, 80 days, up to 360 days. So we're not actually on the extreme range of fasting. We limit it to 40 days. In fact, it's interesting. The gentleman I studied with, I was going to osteopathic college in Australia, and the gentleman's name was Alec Burton, and he had 50 years experience fasting people. He used to fast people up to 100 days. And when I got there, though, this is 40 years ago, he was no longer doing that. He was only fasting people up to 40 days. And I asked him, why, are we limiting it to just 40 days rather than the longer fast that he used to do? And he said, because of sleep deprivation. And he said, I said, do the patients have more trouble sleeping? He goes, not the patients, me. Because when you get beyond 40 days, you start getting more electrolyte balance challenges. You have to be a lot more careful. If you keep it short, you don't go over the 40 days, we don't have too many complications that we have to, be as worried about. So, he limited it arbitrarily just because he found that was the level you could go without it getting too messy. Occasionally, we did do longer fasts when I was there, but most of the time, that's kind of the standard. And at TrueNorth Health, we only very rarely have gone over that. And by doing that, we've had 25,000 people walk in and 25,000 people walk out. And we're trying to really keep it that way because we've got great safety data. And so, we have protocols that we follow. And one of those protocols is to limit the fasting duration to 40 days.
Okay, coming back to my question, somebody comes in, say they have high blood pressure, they're trying to lose some weight. How do you determine between 5 and 40 days how long they're going to fast?
Right.
Because they need to plan this out. They have family, they have work, and they need to have a general idea, at least coming in, how long they're going to be there.
Right. So the way it works is before they come in, they go onto our website, they fill out the registration forms, and then I offer them a free phone conversation where we look at their medical history, we look at their lab, and give them an idea of what we think, based on our experience, is likely the range and duration. You don't know exactly until you see how they fast, because fasting is diagnostic as well as therapeutic. But for example, let's say a person has adequate reserves, because you can't fast people beyond their reserves. Whether those reserves are fat reserves, whether they're electrolyte reserves, whether they're, whatever the limiting factor for that individual is. So we can estimate, okay, we know if the blood pressure, say it's 160 over 110 and they're capped out on some medications, we know from experience that's going to be somewhere between 2 and 4 weeks of fasting. So we guess the longest, because at TrueNorth Health Center, there's no penalty or cost because people get done quicker. So if they book 4 weeks, but it only takes 7 days, it's 7 days. So there's no problem shortening anything. Sometimes it's hard to lengthen just because we tend to be booked out a few months. But, as far as guessing duration, we look at the reserves, their laboratory results, what their condition is. Some people, it's not going to be a single fast. They're going to need maybe several fasts to resolve, deep-seated long-term problems. Other people may not need to fast at all. In fact, often happens. They'll work with our doctors through the telemedicine thing before they come in. And oftentimes, by the time they're ready to come in and fast, they're already better because they've made the diet and lifestyle changes. The people we see at TrueNorth Health are often the people that, despite making the diet and lifestyle changes, still have, some challenges. Or maybe they can't make the diet and lifestyle changes because it's hard for them to get off their medication profile. Or maybe they're having trouble with dietary adherence at home. So we create an environment where they can be more successful. But for most people, it's diet, sleep, exercise. You do those things, you get healthy. Now, what's interesting, though, is we found that healthy people also can benefit from fasting. And we did a study recently where we took metabolically healthy people and we fasted them and looked at what happens. Now, first of all, it was hard finding metabolically healthy people. Only 12.5% of the population are metabolically healthy. And of those, only about 3% of the population don't smoke, have a normal body weight, eat what's considered a generally healthy diet. That's rare. 62% of people now are overweight or obese. A huge percentage of people are addicted to various medications or drugs. So you have a whole population, well over 90% that are not healthy. So we found some healthy people. Actually, a lot of them were staff members at TrueNorth Health. Anyway, We fasted those people and we compared the cardiometabolic risk factors to people that were sick. And what was interesting is healthful as fasting is in sick people, proportionally, it was actually more healthy in healthy people. In other words, they started off with normal weight, but their weight profile improved even more. Their body waist, circumference, their blood pressure started off an average of 110, but ended up at follow-up at 106. And, there's a 1% reduction in all-cause mortality for every point systolic blood pressure drops, probably as low as 90. So healthy people got benefit as well as sick people. The difference is, number one, healthy people, you tend not to have to fast very long in order to get a positive effect. Number two, healthy people fast a lot better than sick people do. They have a lot less problems. People that prepare well for fasting don't have to have the intense symptomology that you often see in people coming off medications, withdrawing from caffeine, alcohol, highly processed foods, animal products, etc. Those patients have a different experience of fasting. It can be a very intense process. That's why we try to get them to prepare so carefully before they come in. The longer and the better people prepare, the easier fasting is. When you look at metabolically healthy people fasting, it's kind of boring because not that much happens. They just go through the process. People that are coming off a lot of medications, a lot of unhealthy diets, they're what I call entertaining because they have lots of interesting symptoms that can be really fascinating during fasting.
Talk more about that prep phase before somebody starts their water-only fast coming to your clinic. What does that look like, including if they're on medications that they need to come off of beforehand?
So some medications you can't just arbitrarily discontinue. For example, if you're on steroid medications, if you're on anticoagulant therapy, if you rapidly withdraw those medications, that can be serious or fatal. So those have to be weaned down. They'll often work with our doctors remotely through the telemedicine practice where we get them to make the diet changes and slowly wean the medications off so that by the time they come in, we're ready to make some reasonable transition off of medication. Some people come in and it's complicated and we have to spend days or weeks working with them to carefully wean their medication. Once they're stable off their medication, then we can go into water-only fasting. You wouldn't want to fast on most medications because the medications can become potentiated. You can get all kinds of problems, even drugs that you normally might get away with, say over-the-counter drugs like non-steroidal anti-inflammatories. In the feeding state, you might get away with those, but in the fasting state, you can get some serious problems with the kidney, liver function, the stomach, etc. So it's really important for people to understand if they're going to do fasting, they really want to work with their doctor in terms of their medication profile. This isn't something you want to do casually, particularly long-term water-only fasting. In order to make it safe and effective, you really have to follow a decent protocol. History, exam, lab, and monitoring is critical. One of the mistakes people make in fasting is they don't prep well, so they have a harder time adjusting, or they prep well, but then they're too active during fasting, so they get into dehydration. And dehydration can lead to atrial fibrillation and cardiac issues and all kinds of problems, fainting, and most of the symptoms that you see associated with fasting as far as adverse events are because of dehydration. And dehydration occurs if people are too active, they're out in the sun too much, they don't take care of business in terms of while they're actually fasting. And of course, drinking enough, but not too much. If you drink too much water, you can flush out your electrolytes and get into dysrhythmia and problems. If you don't drink enough, you can get dehydrated. So that's one of the things we're monitoring. We're monitoring people's water intake. We're monitoring their urine and their specific gravity. We're looking at their blood evaluation. And that's how you can make sure that people stay in balance up to 40 days on water in a controlled setting with appropriate supervision. Now, people don't have to come to TrueNorth Health in order to have a safe fast. But wherever they fast, whether it's at home or whether it's at a facility, they need to follow the same protocols. So there needs to be a history to make sure they're a good candidate. We actually offer that for free. We're happy to review a person's medical history, give them some advice. They need to have appropriate baseline evaluation, but that can be done by their local doctor. We have doctors that will provide remote support through our telemedicine practice. So our doctors can work with them and their local doctor so that proper monitoring can be provided in terms of lab, et cetera. And then they need to rest when they're fasting. They're not driving to work. They're not going to the store. They're not going out and partying. They've got to rest. And they need to refeed carefully and appropriately as they come off the fast. And that avoids the refeeding syndrome. That avoids the complications that people are naturally concerned about as you recover from fasting. So if a person's willing to do that, that is history, exam, lab, monitoring, rest, fasting can be done safely in multiple locations. Now, there are some people that need to fast longer than 3 weeks, for example, or that have complications that really need to be done inpatient with direct medical supervision. But many people, particularly healthier people, may be able to navigate this with the cooperation of a local doctor.
You talked about all the different steps that somebody would need to take if they're going to do this on their own at home. How far could somebody push it on water only? Say they're a healthy individual and just wants to do this as part of a healthy maintenance protocol. What would be safe to do on our own without doing that history and evolving doctors and all that?
Sure, we would recommend that everybody do that on their own every day, but for 16 hours. So we recommend everybody do time-restricted eating, which is don't eat 3 to 4 hours before you go to bed. And then if you want to delay breakfast till you have a chance to do some exercise in the morning, that'll give you a somewhere between 12 and 16-hour fast every single day. And we encourage everybody to fast up to 16 hours every day because you don't have to modify your medication profiles. You can, there's not the restriction or problem for that. And that little bit of fasting every day cumulatively is thought to be of benefit. And Walter Longo and others have different programs out there where they're talking about different versions of this fasting mimicking programs. The long-term water fasting from 5 to 40 days should be done history exam, lab, and monitoring. We like to do it inpatient. If it's going to be done outpatient, you still want to do history exam, lab, and monitoring because even sometimes short fasts in the wrong patients can be very serious. I get those calls frequently where well-intentioned people are trying to do fasting, but they forgot that they were supposed to rest, or they didn't discontinue their medications properly, or they have a condition that contraindicates fasting. They're going to be harmed instead of helped by fasting. We don't want people doing that. And that's why we wrote our book, Can Fasting Save Your Life? Because it helps you and your doctor determine all the things you need to know to get into and through a fast safely. If you look at that book, it has everything, including adverse events and the blood values that need to be done, the changes that occur in fasting, so that your doctor can guide you and understand that the fasting blood work looks very different than blood work in people that are feeding. And it has the culmination of the 18 papers that we've published in the peer-reviewed literature in that book. So that book we're really excited about that book because it gives people the tools they need to understand fasting, to help determine if they're a candidate for home fasting, or if they want to do that at a facility, or maybe fasting isn't for them, but they could focus on some of the other alternative ways of getting healthy by manipulating the diet or juice fasting or other things like Walter Longo's program, et cetera.
When you're talking about the health benefits that somebody could get, even if they're healthy doing a water fast, it got me thinking about the detox benefits of a water-only fast, because we live in this toxic world where there's all kinds of pollution in the air, the water, the food. Talk about what happens when somebody is on water only. What's accumulated in their tissues, what can come out, and the benefits in the detox realm they can get.
Well, when you think about a human being, if you did a fat biopsy, for example, of virtually anybody, you would find hundreds of different chemicals that accumulate: PCB, dioxin, pesticide residues, heavy metals. There's lots of stuff. Some of it got there because people smoke, some people drink, some people take drugs, some people live in LA and breathe the air. But 90% of the average load of the typical person got there from their diet, and particularly animal foods. Meat, fish, fowl, eggs, and dairy products biologically concentrate the pollution, not just from the environment, but from the food animals are fed, the drugs they're given. And so if you look at a calorie, say, of plant foods, and you figure there can be pesticide residues and different chemicals, and you compare it to a calorie of animal foods, those animal foods can have anywhere from 2 to 1,000 times the concentration per calorie of residue because of biological contamination. And so one of the things people can do is just start eating more whole plant foods and less highly processed foods, particularly highly processed animal foods, and you can reduce your total body exposure. In fasting, the body rapidly mobilizes and eliminates these materials. In fact, it does it so efficiently that some people have said, don't do fasting unless you take their proprietary products, because then apparently they think that makes it safe. The reality is that fasting is a biological adaptation. All the humans that couldn't fast died. All the humans that couldn't fast died because the largest burner of glucose in a human being is our brain. And we have a ridiculously large brain. It's 2.5 times proportionally to, say, chimps or something, which, by the way, don't fast and never leave the tropics. You don't see chimps wandering all over the country or all over the planet. Humans do. And the humans that wandered away from that steady supply of food, because the brain is so big, could only have gone about a week or so if it weren't for fasting. A human being, a 70-kilogram male, can fast up to 70 days. Not that they should, but they could. And that's one of the reasons why humans survive, despite the advantages and disadvantages of having a really large brain, is because we can fast. All the humans that couldn't fast bit the dust. And so now we've taken this very natural process and applied it in a very unnatural situation. And that's where people get exposed to dietary excess consistently. The only people that used to ever get dietary excess consistently were called kings. And they developed the diseases of kings, which is heart disease, cancer, diabetes, autoimmune diseases, the diseases that we suffer from today because we're eating like only kings used to be able to eat in the past.
You talked about these products on the market to help with detox. Do you ever find when you work with somebody who is super toxic, they've been living a really classic lifestyle, breathing that toxic air, again, getting pollutants through the food and through the water, that it is too much when they go on water only for their body to handle the things that are coming up and being expelled from the body?
So it turns out the most efficient way that the body has of detoxifying is fasting. Fasting, in my experience, has been more effective and efficient, and it can be overwhelming. But that's why we try to prepare people before fasting. That's why we don't start fasting with people on large amounts of medications and other really toxic products. And if they've had trouble with dietary issue, we want to get some diet and lifestyle changes even before fasting so that level is somewhat mitigated. Now, the other thing is sometimes in fasting, it gets really intense. And so what we can do is slow it down by moving people onto broth and juices for a few days till the body catches up. And then we can often ease back into fasting and things will go well. So if there is a backlog, so to speak, we have tools that we can use to kind of mitigate that whole process. When people are doing fasting properly, though, the body's remarkably efficient at mobilizing. And it'll go to one area, you'll see a healing crisis, something will become acute, then that resolves, and then another area will show up. It doesn't all do it usually at the same time, thank goodness. And we can often watch that pattern and see what the body perceives as kind of the most critical areas. It doesn't always do what we think is most important. Some people come and think, oh, they want this big belly to go away. That may not be the very first thing that happens in fasting. You may have some old, I remember one particularly dramatic result. A person had a chronic ankle problem. They'd had a fracture and some sprains. And during fasting, it looked like somebody hit the ankle with a bat. It kind of swelled up. But then after fasting, that chronic inflammatory process seems to have worked its way out. So the body's pretty amazing. We call these healing crises, where a chronic problem becomes acute, and then somehow the body's able to unwind it. So we're looking at fasting therapeutically, but we also see it diagnostically. We're getting a little bit better insight into where the problems are as far as, in the order of priority.
You must have some wild stories after all these years.
It's remarkable what the body does when you get out of the way. And, we've published some of these remarkable stories as case reports in clinical trials. And, we summarize them in Can Fasting Save Your Life? It's really almost unbelievable to see what we see routinely every day, where these problems that people think about high blood pressure, leading contributing cause of death and disability. If you go to a medical doctor, they're going to tell you, take these drugs. They will have side effects, chronic cough, fatigue, impotence, premature death, but that's the best you can do. And we promise you, if you take the drugs exactly like they're prescribed, you'll never get well. You'll be sick the rest of your life. You'll be on these medications forever. And that's what they say about diabetes. That's what they say about many forms of cancer. That's what they say about autoimmune disease. Nobody ever gets better. It's because nobody's dealing with the actual cause of disease. They're treating the leading cause of death, aren't they? Heart disease, cancer, diabetes, with stents, with bypass, spending billions of dollars without necessarily affecting all-cause mortality. What we're saying is let's stop focusing on the leading cause of death and focus on the actual causes of death. The reason people get heart disease, cancer, stroke, autoimmune disease. And it's the diet, it's the sleep, it's the exercise. These are the fundamental reasons that people are getting sick, and it's the things you have to change if you want to get well.
When you're working with somebody who is grossly obese, do you ever have to do a lead-in protocol where they lose some of that weight before going to water only? Or is water only safe for somebody who is just huge?
Well, overweight itself isn't in and of itself a problem. Fat storage is a normal biological adaptation increased calorie intake. It's what's in the fat, particularly the visceral fat, that seems to be the big problem. So, fat usually isn't a limiting factor to be able to adapt to fasting. What can be a limiting factor, though, is kidney function, liver function. If the organs of detoxification don't have adequate function, you have to work within their limitations. And the way that we do that is preparatory feeding before fasting, and then careful monitoring during fasting. Sometimes the people that look on the surface not to be that bad are actually very, very sick. And some people you look on the surface, oh, they're really fat. That doesn't necessarily mean they're unhealthy, in the sense that people that gain fat easily aren't unhealthy compared to people that don't, eat whatever they want and never gain weight. In fact, if you think about it, people that gain fat easily generally have really good plumbing. They absorb what they eat. This isn't a bad thing biologically. Your ancestors were the ones that went on that long boat ride and survived. The skinny ones that could never gain any weight, they didn't make it. They probably got eaten by your ancestors. The bottom line is getting fat itself isn't the problem. It's the diet you eat that makes you fat that's the problem. And think about this. If you're a diabetic and you make dietary changes, do you have to lose all the fat for your sugars to normalize? No. Your blood sugar starts coming down the day you change the diet, because it's the diet that makes you fat, not just the fat, that's a major factor for these diseases. So being overweight itself isn't some big overwhelming problem. Granted, the visceral fat has tumor-like properties, but the day you change the diet, the fat starts coming off. And if you're a male, you're going to lose on average about 3 pounds a week down to optimum weight just with dietary change. If you're a female, it's only going to be 2 pounds a week. It's going to be about 50% less, because women are full of estrogen, which is a fat storage hormone. If you think about it biologically, females are essentially energy-conserving fat storage devices, because they have to store fat to survive a period of biological vulnerability called pregnancy, which, by the way, men can't do, ever. And so men full of testosterone, a fat-burning hormone, lose weight easier. It doesn't mean we can't be fat, but we have to work harder at it. So getting fat isn't the problem. The diet that makes you fat is, and the moment you change the diet, the fat starts going away. If you do fasting, obviously it goes away faster. Instead of 2 pounds a week, you're looking at 1 pound a day. And of that, some of it's water, fiber, glycogen, and protein. Some of it's fat. But the weight you lose during fasting and the weight you recover after fasting is going to be limited to water, fiber, glycogen, and protein if you're eating well. And we've demonstrated this really conclusively in a study that we did with a significant number of people using the DEXA scanner. And people that go to our website at TrueNorthHealth.com, they can download all of our studies, and they can read for themselves, what the data shows. It's really compelling.
I think what brought that up for me is just picturing somebody with all this fat on their body and tying that to what we talked about before with the toxins and the accumulation in that tissue over all the years, and having just that increased capacity to store toxins that the body's going to have to deal with as all that fat is being burned over time.
Think about this, though, that during the fast, the overweight person, granted, they lose weight at a faster rate than the thin person. But, a fat person might be losing, 1 to 2 pounds a day, whereas a thin person might be losing 0.5 pound a day. So you're really talking about the toxicity that's mobilized from that pound or two of tissue, even though their total body load is higher, and it might take them longer ultimately to eliminate their total body load. The amount that's going on at any one time isn't necessarily worse. And a thin person with kidney disease may have far less adaptation than an overweight person that has perfectly normal kidney function.
When you assess somebody, again, before beginning a water-only fast, is there anything you do specifically to look at organs of detox, things like the kidneys, the liver, the skin, areas that are going to have an increased burden as they go through this process? And then if they are suffering in one of these areas, anything you can do to prop them up? Because
right, so
I know during the water-only fast, you can't be on medications and you can't supplement with anything. So you have to do that work ahead of time and support those organs and make sure the body's in a good place. So talk about that.
Well, so most people are not deficiency driven. In other words, the conditions they have, the plaque psoriasis, the asthma, the eczema, the autoimmune diseases, these are dietary excess, not deficiency. So getting rid of the excess preparatory before the fast, then during fasting, is only going to help drop the body load. And for example, we've got a great case report. You can look at the pictures. 20 years of constant plaque psoriasis, 14 days of fasting, dramatic improvement. 2 months later, resolution. So you can see that skin, which is an important limited organ, responds really well to fasting. Now, sure, during fasting, you can get rashes and what we call fasting rashes and detoxification, but the body's very well equipped to regulate that. Remember, this is a billion years of evolution. This isn't something we invented, 5 years ago. People have been developing these mechanisms in order to adapt to the environment for millennia. The problem is the environment now is much more toxic, but our capacity to deal with it is still pretty good. It's remarkable. You take people who have spent decades abusing their bodies, and in weeks or months, you see, just remarkable resiliency. The body's ability to heal itself is absolutely fascinating. And the time you get to see it best is in fasting. And when you see how the body unwinds these things, sometimes very rapidly, it's very, very impressive.
We talked about one extreme, somebody coming to you who's grossly obese. We quickly touched on somebody who is normal weight or underweight and how that's a point of caution for you. Talk more about that. Somebody who is, say, underweight, but there would be other benefits to doing a water-only fast. And the extreme example of that would be cancer, where somebody's got cachexia and they're in a very depleted, low-weight state. Anything you can do with people in that realm, or does that take fasting right off the table?
No, we don't fast people whose BMI are extremely low, like under 16. We normally wouldn't use fasting there. We would first build the person up and then do short-term fasting. So what you may see is serial fast, where you do 2 or 3 days of fasting and you do some refeeding, and then you do another 2 or 3 days of fasting until their capacity increases that they can do longer fasting if necessary. So long-term fasting, not for everybody, certainly. And sometimes fasting is not good at all for a person. We won't do fasting. We might do a modification of fasting, though. We might put people on vegetable broths and juices and other things, so they're getting some calories, they're getting some electrolytes to compensate for their limitations. And it's slower. You don't get the very rapid change you do with fasting, but it doesn't really matter. As long as you're getting healthier fasting than you're getting sick and old, you win. And so the doctors we have at TrueNorth Health are very conservative. There are these people that are concerned about, obviously, good safety outcome. In this field, what we do used to be considered criminal quackery, and now it's kind of cutting edge research, but you still have to have good outcomes. If you don't have good outcomes, if you're, no matter what you do, they'll want to blame fasting for the outcome. If a person's property taxes go up, they'll say, oh, well, you fasted last week. That's probably why your property taxes went up. There's a lot of errors of attribution that are made. So we try to cherry pick out all the people that are going to have really good results so they make us look good. And so, we have really impressive safety study that we published that shows all the adverse events that occur in fasting in patients over 5 years, hundreds of patients. And what you'll see is that most of the adverse events are category 1 and category 2 events. These are the low back pain, the nausea, the skin rashes, all the stuff you expect to see in fasting. There's no death, so we have 0 death. We have very little category 4 events. Mostly they're things like low sodium levels or dehydration-related issues, which are easy to solve, but you have to break the fast. So a problem like low sodium levels, if you break the fast, not an issue. If you don't break the fast, though, theoretically, that could become a very serious or life-threatening problem. So it's one of the reasons why monitoring is critical. Now, granted, it's rare. We're talking less than 1% of patients have what would be considered medically significant complications. And most of those are easily dealt with just by monitoring it, not letting it get out of hand. But when you have a lot of sick people around and you do something vigorous like fasting, there's definitely going to be requirement for monitoring. And the problem is it's not always the overweight person or the older person or the sick person. Sometimes people that look on the surface relatively healthy can still run into problems. They may develop atrial fibrillation, or they may develop a problem that may be easy enough to treat if you recognize it, but if you don't, could end up with a problem.
And I would assume arguably the stage 1 and stage 2 problems, quote unquote, would be looked at as a good thing in your, from your observation, because it means things are changing and healing is happening in the body.
Yeah, it's a different way of seeing those symptoms. But again, it's the important thing to realize these are not problems that are residual. They don't last after the fast. These are things that happen during fasting, resolve during fasting. And they're like, we even know what percentage of people are likely to have that now. If you look at the studies, you'll see, well, how many people have nausea, stage 1 through 2, and how many people have skin rashes, how many people. So that data now is becoming apparent because we have thousands of patients and we're able to track and monitor. So in Can Fasting Save Your Life, in the book, we go through all of that so doctors can see who's a good candidate, what are the complications, how do we address those complications, what's the easy solution. The important thing with the adverse events is to catch them early enough that they don't become a serious medical problem. And we're doing that very effectively at TrueNorth Health, and you can see that by looking at what percentage of people end up with problems that need intervention.
Up until this point, we've talked about physical effects of water-only fasting, and we talked about building the body up beforehand. Let's get into psychological. So somebody who you're assuming at the beginning is going to embark on a 40-day water-only fast. This is a new thing to them. Maybe they've never even water fasted. How do you prepare them and build them up psychologically in that period before they begin to take on such a long, enduring process?
Yeah, it turns out that most people adapt to fasting state quite well. The biggest challenge I know, including for myself, is that in fasting, you're resting. So some people have trouble being alone and with themselves and by themselves. But at the center, for example, where we do it at TrueNorth, you're with 75 other people from around the world, oftentimes interesting people. So it's not quite such an isolating feeling if somebody say fasting at home. The ability to rest, the challenge of being with yourself and being with your own feelings can bring up a lot of issues for people. In fact, it's interesting that, the Jews and the Jains and the Hindus and the Muslims and the Christians don't all agree on everything. But they all have a tradition about fasting, and not just for spiritual, but also for physical, health benefit reasons. So this fasting business has been going on, since we've been recording written language. And there's a reason, because it does change how you feel about yourself and the world around you. We are not a spiritually driven organization. We're a health organization. We have doctors with all kinds of different backgrounds and religious beliefs, and we respect all the diversity in religion. But we don't know, for example, how people are supposed to get into heaven or what to believe, and we don't impose our beliefs. We don't have any expertise in that regard. We defer that to the churches and the synagogues and the other people that are experts in religious belief systems. But you can't deny the fact that people do have a profound experience oftentimes during fasting. So we just try to create a very neutral environment to support people in that transition. And just like healing, those types of responses also tend to take spontaneously. I don't know that they require outside intervention in order for them to, maximize their potential in that regard.
You quickly touched on this, but I'm curious about this specific aspect. The fact that people are alone with themselves during this process, and again, not totally, they're with other people doing something similar, but going from today's fast-paced, go world where we're always connected to a computer or a phone and scrolling, and this is going to be a profoundly different experience for most people where they have time to think and time to assess their where they've come and where they're going in life. I can imagine for a lot of people, the psychological aspect of slowing down and looking at their life and not having all these distractions, food being a major one that a lot of people are using as a distraction, that they're going to face a lot of things that they've been either consciously or unconsciously ignoring over the years.
Well, one of our premises is with the pleasure trap, that the hidden force that undermines health and happiness is the artificial stimulation of dopamine in the brain that comes from the chemicals that we add to food: salt, oil, sugar. So whether you're addicted to alcohol or caffeine or nicotine or salt, oil, and sugar, one of the things that happens in fasting is you're going to resolve these addictions. You're going to withdraw from those stimulants and those medications, and it can be a very intense process. But it's also very empowering. Some people believe if you got on a plane in New York and you flew all the way to California, you would die over Colorado from starvation if you didn't eat the pretzels. And by the time people have fasted for a few days or a few weeks or a month or more, they no longer are worried if they're going to survive getting from New York to California on the plane. They're not only are they not worried about starving? They're also, their blood sugar levels tend to stabilize. They don't have the binging, the craving. A lot of these things that people struggle with go away as a consequence of fasting, and it's very, very empowering. And also we call it education. It's essentially brainwashing. We have classes and lectures and all kinds of stuff to empower people so when they go home, they can make the behavioral changes so they get a good long-term outcome and make us look good. So, part of the challenge is not just getting people well, but it's encouraging or inspiring them or intimidating them into staying well. That's really where the power comes. That you can show that people a year, 2 years, 5 years, 10 years later. I'm getting 35, 40-year follow-ups now on patients. And what's really interesting is these people that I started treating when they were in their 40s, and now they're in their 80s. And the same story you hear over and over again. They've outlived everybody they knew, including in some cases their kids, who are dying in their 60s of heart attacks from the diet that they didn't adopt. And here they are in their 80s, and now they're still sharp as tacks, doing well. And part of our hope is that the last 20 years of people's life can be the best instead of the worst. And the way you do that is preserve health. It's the stroke and the heart attack that gets the person debilitated. They find themselves unable to talk or move, lying in some nursing home bed waiting for people to come and change their diaper. We're trying to avoid that, delay that, so you have a good life and then a good death where you go to sleep and don't wake up, rather than spending years or decades debilitated, dependent on the people around you. And that's what we're seeing happen, is people are able to not only get healthy, but they're able to sustain their health, and then they have a much shorter period of debility. Instead of years of debility, like I say, they reach their potential at some point. We're all going to die. We know that. And then they go and not have that long tail of debility. And that, by the way, that's where most money is spent on medicine, doing things that don't necessarily reduce all-cause mortality or even improve the quality of people's life. They suck a lot of money out of them doing a lot of treatments that should have been avoided with prevention.
You talked about the empowerment of even knowing when you're on a flight, you don't have to cave and eat the pretzels. There's also a bigger level of empowerment as well, where say you accomplish 30 days, 40 days on only water, that in a different way is like climbing Everest and having this new benchmark and this new outlook on life that you're going to take into everything from that point forward.
I would say there's probably more people that have climbed Everest than have done a 40-day water fast at this point. So, I think you're right. People see it as a really significant impact and they feel it as a big impact. And again, not everybody needs to fast 40 days. 40 days fast is a small percentage of our population. Most of the people at TrueNorth Health Center are fasting between 1 and 4 weeks. So, it's normally a shorter period. The advantage to shorter period is also quicker recovery. It doesn't take as much time. It's the 40-day fast, more extreme version of it. That's kind of the end of the curve, not the center of the bell curve.
And for somebody that does go longer end on your curve of that 40 days, do you ever find that they have these deeply profound spiritual experiences, almost like psychedelics or religious type awakenings, for lack of a better word?
Well, it doesn't just take 40 days fast. I mean, I have people that are sharing stories with me from even relatively shorter fasts that can be very profound. I know myself, fasting is a very powerful tool. And I don't know that it's quantitatively limited. In other words, I don't think you have to do the marathon Jesus fast to get, significant impact. But it is true that, for many, many people that have done long-term fasting, they will explain as part of the benefit of that, a change in how they feel about themselves and the world around them.
You talked about veggie broth, juice. And earlier we talked about intermittent fasting. Somebody who is going to fast using one of those modalities, whether it be the veggie broth or the juice or intermittent fasting, how do the results differ from doing water only? Because this is the most extreme. Actually, dry fasting would be, which I want you to comment on. But what kind of benefits does water only fasting provide that we're not going to see with introduction of these other, food-like substances, juice and veggie broth, and intermittent fasting?
Well, I think that the juice fast, the intermittent fasting, all these programs clearly have benefit. I mean, there's many, many, many more people doing that than doing the more extreme water-only fasting. It's safer. You don't have the hydration issues. People can do it with less supervision. There's a lot of benefits to these more modified fasting mimicking programs. So the problem is some people, despite doing those, still have challenges. They've done the diet, but their blood pressure is still too high. Their joint pain is still there. Their tumor hasn't gone away. And that's where water-only fasting can it's a much more impacting. It's faster. It has a more powerful influence. So for those people, they may not be able to accomplish their goals without water fasting. But for many people, in fact, probably most people, if they're just persistent with the diet, the sleep, the exercise, they use the intermittent fasting as tools, they're going to achieve their goals. They're going to lose their weight. They're going to bring their blood pressure down. They're going to see improvements across the board. Not everybody will have their problems resolved. And those people are often the people we see at the TrueNorth Health Center. Dr. McDougall is a famous plant-based doctor who will occasionally send us people, but he does it and apologizes to the patient. He'll actually say, I'm so sorry to do this to you, but your problem is persistent. You need to go see Goldhamer. Good luck. Because, he will send us people that have problems that maybe diet alone hasn't been sufficient, or maybe they haven't been able to adhere well enough and they need a more structured environment. That's why they call us TrueNorth Health Center the last resort, because we're kind of a structured environment for enforcing diet and lifestyle change or using fasting. And, we've had success with the people that we treat.
And at this point, what percentage of the people you're working with are healthy, looking to optimize and maintain, versus really sick?
About 80% of our patients are coming in heavily motivated by specific conditions that they're trying to overcome. And about 20% are people that used to have serious conditions, but now are doing fasting preventatively and health promotion. But I expect that percentage is going to change as people read our new book, Can Fasting Save Your Life? Because we've never talked before about the benefits of fasting in healthy people. We've only talked about fasting in sick people because that was our experience. Now we've done this study. We're going to be doing a bigger study looking at, I think, who's going to get the most benefit from fasting are healthy people that are using it preventatively, shorter term, healthy people fasting. So I expect we'll be seeing more and more of those kinds of patients. And as we do this big study, we'll be enrolling a bunch of people in this long-term study. But at this point, of the 25,000 people that we've seen, probably 20,000 of them were motivated by specific health concerns. So obesity, hypertension, diabetes, autoimmune disease, cancer.
You mentioned the fact that people that are on the grounds, I think it's 75 people you can have there at once, which is very limiting. Do you see down the line expanding out and having multiple clinics? Are there any other clinics that are separate from you guys that are doing similar type work? And I just want to caveat too, you did mention before that people can do this from home as well, which is expansive on what I just said, if they have a doctor that can work with them. But talk about TrueNorth and where you guys are going. If there is any changes, maybe 75 is your capacity and that's what you feel good about. And then other clinics that are doing similar work.
Right. So we have an active residency internship program. So doctors can come. There's no cost to the doctor. We provide them room and board and training, and we'll teach them how to use diet and fasting in order to get people well. And we've had a couple hundred doctors so far that have gone through that process. We're a residency training site for the naturopathic profession. The chiropractic students can come as part of their training. And we have a number of medical schools that are referring patients for a rotation, so they can get some experience. So what we're hoping to do is encourage other doctors to open up. Some have. We have doctors that we'll refer to geographically that do this. Most of them are small clinics. And that's been great. There's a lot of doctors in practice that are sympathetic to fasting, and they'll work with the patient that's staying home, and our doctors can provide them the daily support and the encouragement. The doctor may not be that familiar with fasting, but they can evaluate the person's health. They can do the lab. They can take care of that. We can provide them some remote coaching or provide support to the doctor to help them get the patient through the process safely, as long as they're a good candidate for that. And I think that we'll continue to expand that. We keep adding doctors to our telemedicine practice because right now we're actually doing more visits with patients that are remote than we are with people that come to the clinic. That would treat the whole world. During the pandemic, we had to do it because people couldn't even get into the United States. And so we were doing a lot of work. 15% of our population are from foreign countries. And so we have kind of a broad audience of patients. And also, we're hoping to be able to partner with, for healthier people, we'd like to do some large-scale fasting experiences using redundant capacity in hotels and in different places so we can bring the fasting to people. So we're looking at developing that. We've got to do some studies showing that that can be done safely as well. So we're working on that right now. We're working with a local HMO on a hypertension study, trying to show that, we can train their staff to be able to provide remote fasting support safely. One of the problems is up until recently, fasting was really seen as like crazy. It's only recently, in large part because of people like Walter Longo publishing in Journal of Metabolism and having a big impact on the big exposure, that fasting has become more acceptable. In his book, he talks about intermittent fasting and also not to do long-term fasting because it's too dangerous unless you do it at the TrueNorth Health Center, because he's seen our safety data. And since I evaluate other researchers' intelligence based on how much they agree with me, I consider him a genius,
Talk more about the evolution of fasting. You touched on the fact that it's becoming more accepted, but you've been doing this for so long, decades. Talk about the landscape back when you opened TrueNorth, and then what it must feel like for you to see this acceptance over time and this explosion of fasting, intermittent fasting, throughout a relatively short period of your career. So it's like, to me, I'm curious on the polar difference there over the number of decades you've been doing this.
Well, yeah, it's been a long time. I've been doing 40 years. I started when I was 16 years old getting interested in this. And that's really all I've been interested in. That's all I've done for the last, whatever that is, 59 years. 40 years in practice. When we started, it was a real problem practicing because it really was seen as criminal quackery. People thought we were insane, Jim Jones crazy type, stuff. So we kept a very low profile. We have never advertised. We've never been in the phone book. We don't do any kind of, marketing or anything like that. In fact, that's why most of our patients come from out of state or foreign countries, because I never even spoke locally. I never did local presentations. They were always out of state, out of area, just to keep people from getting too excited. And that slowly transitioned over time. And then, of course, the internet became a phenomenon. And we wrote a book called The Pleasure Trap. And The Pleasure Trap, kind of exposed us. And it continues to do well. But we never really wanted to push that public visibility just because we were concerned about how everything was perceived. Once we started publishing papers, though, then it became a little bit more credible. People, they still thought we were crazy, but at least they could see that we were taking it seriously and trying to document it. We published the first safety study on the use of fasting, so it was pretty well identified. And so then it was like, as long as you didn't have a bad outcome, you were okay. They weren't going to come and knock your door down just because you're fasting people. They would only come after you if you had a bad outcome. And so we got really selective about trying to only take people that were going to have good results. Then I did a show with Rich Roll just a few years ago. And for whatever reason, it had huge impact. Millions of people viewed it. It drove a tremendous amount of traffic to us. And it gave me an opportunity to do more podcasts and things because there was interest in fasting. You could talk about it, but that completely opened up us because then everybody knew we were there. Because you got people who walk up to me in Costco and are asking questions and taking pictures of the cart. You know what I mean? So I had one guy come up to me. I was just walking on the street, and it was shortly after the movie What the Health came out, and I had talked about dairy products as essentially being cow pus because there were 750,000 pus cells per cc. I said it was like taking a cow with a festering wound and sticking a straw in it and sucking. I think that was the. But anyway, this guy comes up and he goes, "Hey, I know you. You're Dr. Cowpus." That's what he remembered. So now it's a different environment for us because people kind of know we're there, and it's good and it's bad. It's good because now when we want to recruit patients for a study, we have 50,000 patients in a base we can recruit from, and people know about us. We can get exposure. It's potentially bad in the sense then you become kind of a target too. So there's people that don't have good intentions, but then they'll, try to take advantage of situations. So, I'm adapting and adjusting to it. But now we've taken all the lids off because we've got this new book, Can Fasting Save Your Life, which is a product from our research foundation. And we want to get it as broadly exposed as possible. So now I'm going to do every show, whatever it is people want, we'll try to get that message out there. Because I think if people read this book, it will change the attitude about fasting and give people the tools they need to make sure it's done safely. My biggest concern is that fasting get misused, and then it'll get a reputation as being dangerous because people haven't, applied it properly.
Over the years, have you ever had government come in and knock on your door and want to do tours of the place, or the FDA, or some higher ups, or have you been pretty left alone?
Oh yeah, you've had some huge challenges. We've spent a lot of money on lawyers, but mostly defining whether or not whose jurisdiction we fall under and what effect they want to have, from DHS and DSS and the medical boards and all those things. That's been in the past particularly big challenge. Most recently, we were having challenges because there's a law in California that mandated forced vaccination for employees of healthcare facilities. And, the local people knew that we were expressing concern about that, that we didn't think that was necessarily, good public health practice. And as a consequence, that, we had to fight a legal battle in order to be able to continue to operating around that. Now it turns out, now it's changing a little bit. We're publishing studies now on long COVID and COVID vaccine injury. And so, now a lot of what our fears actually became actualized, and it turns out there's, more arguments made on both sides of that whole coin. Major study recently in Europe looked at myocarditis in children that appears to occur dominantly in vaccinated kids, not unvaccinated kids. And so, there's certainly lots of controversy around this, but the point is, because we take public health stands that are somewhat at odds sometimes with conventional authorities, particularly around drug utilization, where we think, like, example, we don't tell patients you have to be on drugs for the rest of your life. We're saying, no, we want to get you off the medication. That's a huge contradiction to conventional management of, say, patients with cardiovascular disease. So we definitely had potential issues. But fortunately, because we're publishing data showing that what we're doing can be done safely and effectively, we're able to make that argument now and not have to be, hiding out. So I think that as time goes on, it should get easier and better. But I guess we'll find out now with the exposure from Can Fasting Save Your Life, because we've laid it all out there. And so, we're certainly open to whatever criticism people want to give us, and we'll take it all seriously. But I think that we're doing the right thing for the right reasons, and hopefully that'll come across as time goes on.
Earlier in our conversation, you mentioned lymphoma quickly. How big of a percentage of people coming to see you with chronic disease is lymphoma and other cancers?
Well, it's become a much bigger percentage since we published a paper in the British Medical Journal, Case Reports, that showed the successful resolution of a patient with follicular lymphoma, a 3-year follow-up, and now a 10-year follow-up. And now we've got a case series of patients, including with even more serious versions, metastasis into the bones, et cetera. And that's been accepted for publication. And what we're hoping to do is justify a clinical trial where we will randomly assign patients to conventional care versus fasting and dietary change and see what works better, getting people well or keeping them sick. So, we're optimistic that a random assignment to condition long-term prospective study will put to bed the issue of safety and efficacy with a number of conditions. We've done that with high blood pressure. We hope to be able to do that with lymphoma as well. So now we've been treating a lot of patients, in part because that was such a spectacular outcome, and it was published in such a prominent journal that we got a lot of exposure. Now doctors are referring us patients that would prefer not to go through treatment that doesn't reduce all-cause mortality in lieu of a conservative approach like fasting.
Let's take a hypothetical patient. They've gone through the entry phase. They're a good candidate to do a long water-only fast. They begin the process day 1. I'm curious on the different physiology that happens early on in the fasting, and then over time, all the way to 40 days, things like going into ketosis, autophagy, these different buzzwords you hear in the health space. Let's go over that process as it unfolds on a water-only fast.
So basically, all of those processes, the conversion to ketosis, you'll within about 24 hours to 48 hours, depending on the individual, they will have depleted their glycogen stores, so their sugar stores. And so now they're going to have to get their energy from either breaking down fat and going to ketosis, and the brain changes fuels from burning sugar to burning beta hydroxybutyric acid. So now you've got a fuel change. And as you get farther and farther into fasting, that becomes more and more profound. By the end of the second week of fasting, the vast majority of energy is being derived from fat. So that's just a huge change. Normally you're burning glucose, now you're burning fat. That has some interesting effects. For example, cancer cells have high metabolic rates. They're not like normal cells. They need a high glucose environment. When you create a ketotic environment, cancer cells have trouble getting the energy they need. They become more vulnerable to the immune system and even more vulnerable to chemotherapy. And in fact, Walter Longo showed in rat studies where you take 30 rats and they all have cancer, you give them enough chemotherapy to kill all the cancer cells and all the rats die from the toxicity from the chemotherapy. And you got to kill all the cancer cells or the cancer comes back. So then they take the same rats, genetically bred rats with the same cancer, the same chemotherapy, but they fast the rats periodically, and all 30 rats survive, dramatically enhancing cancer-free survival. And that's where differential stress sensitivity was identified. The idea that cancer cells are more vulnerable in the ketogenic state to chemotherapy or just to the immune system, and that healthy cells are actually protected from the damaging effects of chemotherapy by fasting. And I think that's when the pharmaceutical companies showed some interest, and fasting went from criminal quackery to cutting-edge research, because they said, oh, fasting could allow us to give more drug with less toxic effect. It might give us a more effective outcome. And now they've been desperately researching, trying to figure out how to come up with fasting mimicking drugs. So what they want is a pill they can sell that'll do to your body what fasting does without having to do that nasty fasting.
Get into autophagy. When does that come about and some of the benefits there?
Well, it's always happening. So autophagy is self-eating. It's how the body's eating up cancer cells and eating up age cells and recycling. And you're constantly forming those cells, and your body's constantly trying to get rid of them. And if it gets rid of them faster than they're forming, you stay okay. If they form faster than you get rid of them, you're aging, you get cancer, you grow tumors, and then you die. So the idea is this autophagy is always happening. If you look at the work by Yoshinori Ashumi in 2016, which is relatively recently, he got the Nobel Prize for Medicine for kind of recognizing this autophagic process. It turns out fasting turns up autophagy. And that may be why we see things break down in fasting that don't break down in feeding. It's because the increased autophagy is associated. Why does the lymphoma tumor goes away? You know, they've had 2 years of progression, 21 days of fasting, it's gone. How did that happen? Well, whatever's going on in fasting was happening a lot quicker than what was going on in the fed state. And this is, there's a lot of biochemical mechanisms. If people really want to get into the details, get our book, Can Fasting Save Your Life? Because Tasha Myers, our director of research, wrote the chapters in there all about all these complicated changes. And she's a great writer, and she makes these complicated things much more understandable. But she does go through and well document what we know about and what we think we know about all these processes that are going on in fasting. But essentially, that's what's going on. You're just seeing the turning up of these healing processes, the turning down and the alterations of these metabolic processes. What's interesting about fasting is that as you get deeper into it, you see kind of geometrically more impact. So you may not see any change for the first, say, 19 days of fasting, but then all of a sudden you'll see this rapid change. And that's the problem, is we don't know how to predict that yet. What we need are non-invasive diagnostic markers to tell us who should fast, how long to fast, when are they done fasting. Right now, we have to rely on our clinical experience because there's not good testing yet, but we're trying to do that testing. The problem is, though, we're the only people that I know of that are doing long-term water-only fasting testing, because everybody else is doing more of the modified, the intermittent fasting and that, which is great. And I'm sure we'll learn a lot from that. But the long-term fasting is a little bit extreme seen. And so now it's hard to get people doing that research. In fact, we had to form our own IRB, Human Subject Committee, with federal-wide assurance in order to be able to get efficient approval of studies, because the regular Human Subject Committee said, oh my God, don't eat, you would die. Everybody's going to die. They just were so panicked about it. It was really hard to get the studies approved. Now we formed a committee with doctors that actually know about fasting, and as a consequence, it's much easier to get these studies approved.
Talk about some of the parallels between water-only fasting and exercise. Autophagy would be one. We were just talking about autophagy. BDNF, I know that's another one.
Yeah, brain-derived neurotrophic factor.
Expand on some of these parallels.
So BDNF is really interesting. They noticed that rats that exercise, like for example, they'll take rats, again, genetically bred rats. They're exactly fed the same. They're kept in the same cages, but one half of the rats will be given a wheel and they'll use it. They'll exercise. The rats that exercise don't get Alzheimer's disease. They don't get the rat dementia. And they said, well, why? What was it about exercise that kept these rats from getting dementia? And they found out the rats that exercise, one difference is they have dramatically higher BDNF, brain-derived neurotrophic factor. Brain-derived neurotrophic factor is a chemical that prevents oxidative damage in the brain. And oxidative damage in the brain is thought to be one of the things that contributes to dementia. So that made sense. And then you take rats and you periodically fast them, you double their lifespan. And it turns out they have, and don't get Alzheimer's, and they have dramatically higher BDNF. And you might think, well, why would exercise, which is very vigorous, and fasting where you're resting, have the same biochemical effects? That seems not intuitive. But if you think about it very carefully, you realize, what do exercise and fasting have in common? They both undo the consequence of dietary excess. So they're getting rid of fat and they're getting rid of visceral fat. And visceral fat is a source of oxidative damage and inflammation that's thought to contribute to everything from dementia to heart disease to cancer to autoimmune disease. So it does make sense that exercise and fasting would have stuff in common, and they do. And if you look at if you measure the biochemical parameters of benefit with exercise, you often find they're paralleled with fasting. And it's probably because all these things we do that get rid of dietary excess have some benefit.
Well, let's talk about the tail end of a longer fast. Somebody who is getting ready to introduce food will use 40 days, go to the extreme.
Yes.
Your extreme. What does that look like at the very end when they're preparing to start eating again? And then what are the first meals?
It may be the most important part of fasting. And it's the one that people that are fasting on their own usually mess up. Because you haven't eaten for a month or two and you start eating and your brain says, oh, great, back to eating. And the tendency is to overdo it. And we learned that, in World War II, when they liberated prisoners of war that had been starved, and then they refed them too quickly, they developed what's called refeeding syndrome, electrolyte imbalances, and sometimes they would actually kill people from too rapid a recovery, and particularly a 40-day fast. It's a very vigorous process. The body's gone through massive metabolic adaptation, and it takes a while to get out of that adaptation. For example, at that point, your HOMO-IR, measures of insulin resistance, is going to be higher. And it's going to take half the length of the fast for those metabolic switches to kind of kick in. And if you try to push that too hard, you can get really sick. You can get post-fasting edema. You can get refeeding syndrome. We don't see that at TrueNorth Health Center because we have a very specific protocol that we follow. In fact, we've laid it out in Can Fasting Save Your Life? But basically, it's this. It takes half the length of the fast to recover. So if you have a 40-day fast, it would take 20 days to recover. For every week of fasting, there's 1 day of fresh fruit or vegetable juices, that type of thing. So no fiber, fruit and vegetable juice. We introduce some glucose. It's about 600 calories, get some electrolytes in there. And then we introduce raw fruit and vegetable material. Again, low caloric density, has a little bit of fiber. So it'd be a day of raw food for every week of fasting. So now we're at day 8, and now we introduce more concentrated foods, a little bit of steamed vegetables, starchy vegetables, your potatoes, your squashes, these kind of things. That's another 4 days. And then we're introducing more concentrated foods, grains, beans, nuts, seeds, in small quantities. So by the time we get to half the length of the fast, we're on a whole plant food SOS-free diet. And then we ask people to stay on that diet as they go home so that we can get some good long-term, results. But the too rapid pushing on the feeding or getting into, say, salty materials, drink some V8 juice or eat some soup at a restaurant, and you can get, post-fasting edema, swelling of the legs, you can get congestive heart failure, you can get problems, particularly in vulnerable people. That's why we require half the length of the fast being done in an inpatient setting. So if you can't refeed properly, we're not interested in trying to do that. The problem with home, again, if people do really long fasts, they still need to have recovery time. And usually people feel so good after fasting, they want to go out and they want to go back to their normal activities, and that's understandable. The good news is most of the people fasting at home are doing shorter fasts. It's 5 to 10 days. It's not 25 days. It's not 40 days. And so their recovery time is proportionally smaller. So a 5-day fast only needs a couple days to kind of get back into the swing of things. A 10-day fast might take 4 or 5 days to get back into the swing of things. And so as long as people do this right, they're going to have a good outcome. When they don't do it right, that's where you see, if you go on YouTube and hear about criticisms, It's not fasting that's usually the problem. It's the refeeding protocols or who was fasting. The real, think about this, 25,000 people in a row, many of them old and often sick, but everybody that walks in walks out. There's hardly anything you can do that has that kind of safety protocol. You can't give 25,000 people ibuprofen without some of them getting into kidney problems and bleeding and things. And, you can't give 25,000 people aspirin without seeing some secondary effects of gastritis and whatnot. Fasting, when it's done right, has a very good profile.
I can imagine towards the end of a longer fast when somebody is starting to think about breaking that and coming back onto juices and then food, they could go one of two ways, where they're either excited to start eating and counting down the days, or feeling nervous because they're probably feeling, like you said, energetic. They're in ketosis. They're seeing all these health complications that have been around for a long time starting to, or hopefully by that time, dissipated. And they're like, I don't want to go back to what I was before. So talk about what you see with patients when they're, say, day 35 and they're seeing the end of the fast coming up. Do you see both of those extremes?
You do, absolutely. In fact, people with autoimmune disease have been in agonizing pain sometimes for decades. And the first time in their life, maybe, that they remember since the onset of their disease, they're out of pain. And they're so nervous that, they like not being in pain. And they're nervous that they're going to get, it's going to be causing them problems. And so we do have to deal with some anxiety and other things that come up as people come off the fast. But it's a very supportive environment. They're working with, people that are experienced at helping people get through that process of adapting to and coming out of fasting. So I think these issues are almost always very easily managed, particularly, given the experience that we have. But most of the conditions that we see, most of the patients we see, I say, have conditions that do respond. By definition, we're trying to select the people that have conditions that are most likely to respond. If you have a condition we don't have experience with or we don't believe is likely to respond to fasting, we have no motivation to try to induce those patients to do fasting.
So when it comes to that period of time where food and juice is being reintroduced, any supplements that you like to use at that time to rebuild things back up and give the body the nourishment that it hasn't been getting?
Yeah, we specifically don't want to use supplements.
No, I know during you don't, but afterwards.
We don't want to use supplements during the alimentation phase because we want to grow a normal microbiome, and you do that with whole plant food diet. And isolated concentrated supplements often create a lot more problems than they solve. They have drug-like effects. People can read Dr. Campbell's book, Whole, and it really talks about the difference between getting your nutrients from whole food rather than from pills, potions, powders, and concentrated substances. So although we do recommend supplementation routinely for people, things like vitamin B12 for vegans, vitamin D for patients that are not getting in the sun enough, we want to be really careful about these isolated concentrated nutrients, particularly as we're trying to give the body a chance to recover from fasting. So we don't supplement during fasting. We don't supplement initially as we come off the fast. And then, depending on the patient's needs, we want to be on the least amount of pills and potions possible, but whatever's necessary to support that person's long-term health.
All right, let's move into the SOS diet, the diet you recommend for people when they are finished their water-only fast and that they stay on indefinitely. And up until this point, we've seen pretty eye to eye on most things, but I think this is where we differ a little bit. Talk about why you recommend people stay off sugar, oil, salt. I think we can all agree on the sugar piece. I don't know how anybody would argue otherwise. But the oil and the salt, I think we need to really get in and explain why you're against those.
Yeah, there are people out there advocating for higher sugar intake. So, I mean, there are, if you go on YouTube, you can find people that'll tell you just about anything.
So when you say sugar, are you talking about refined sugar in that case?
Yeah.
People will say to eat that? Why and who?
Well, I don't want to defend their nonsense, but the point is sugar, I think there's pretty good consensus on. Refined carbohydrates, which make up 86% of the carbohydrates that people in industrialized countries eat, the sugar, the flour products, empty calories, they alter the insulin response, they lead to cravings and binging, they lead to obesity, they alter the gut microbiome, they suppress the immune system. Not a good thing. And the less, the better. And we can argue, some people argue what percentage is good. Something that's bad like that is bad in small quantities, it's bad in big quantities. It's just less bad in big quantities. It doesn't make small quantities good, it just makes it less bad. So let's just agree, refined carbohydrates are probably not a healthy component. They're certainly a major contributing factor to obesity and the visceral fat, et cetera. Oil. A lot of people think, well, there's good oils and bad oils. What there are is oils that are less bad, like olive oil might have a better profile than, say, cottonseed oil. It doesn't mean that olive oil is good. It just means it's less bad than some of the other oils. It's still a highly fractionated 9 calories per gram of fat processed food. We believe the fat you eat is the fat you wear. If you want to maintain optimum weight and optimum visceral fat, you don't need oil. You get all the essential fatty acids you need from a whole plant food diet. So fruits, vegetables, grains, legumes, nuts, and seeds, provide the material that people need in order to sustain long-term health from our viewpoint. Some people will argue that they think you need to have some fractionated oils in order to get enough essential fatty acids, or they want to get a higher ratio of a certain fatty acid to make up for other foods they're eating. I would disagree with that. I think we can build a compelling case that a diet from whole plant foods provides we're talking 15 to 18% of calories from fat, 10% of calories from protein, the balance coming from whole plant food carbohydrates. There's good evidence to support that that's a stable, health-promoting long-term diet. And we know from our own personal experience with 40-year follow-ups on patients, people following this diet are able to sustain health. They don't get the heart attacks, the strokes, the other issues at the same incidence that people eating a conventional standard American diet do. Where it's more controversial is around salt. Now, salt is an essential nutrient without which you die. It's so critical to human health that your body's designed to detect it in very small quantity. In fact, that's one of the reasons why you know that plant-based foods like vegetables and things are valuable, because you'll pick up the very small amounts of sodium that there are. People on conventional diets don't even taste it, but people on a healthy diet, low-salt diet, will taste chard, and it's like, whoa, it's very compelling. So the question is, how much salt do people need? The American Heart Association says 500 milligrams a day. Other sources suggest 1,000 milligrams a day. People generally would agree 1,500 milligrams a day, you're going to meet all your biological needs, including for athletes that are sweating and have higher salt exchange, because their sodium intake is also to increase as their caloric intake goes up. So a person burning a lot of calories is going to burn 3,000 calories rather than 1,500 calories. So they're the same ratio of sodium per calorie, though, doesn't change because you're an athlete. Your caloric intake goes up, so does your sodium intake go up. It doesn't necessarily go up disproportionately. So the point is, we can agree that there's medical standards about how much sodium has to get in. The question is, what's the best way to get that? It turns out, just like you get all the carbohydrate you need and you get all the fat you need from a whole plant food diverse diet, you get a lot of sodium. You get around 1 gram a day of sodium. So the point is, that is going to meet people's biological needs. You don't have to fractionate sodium out and add it to the food in order to get enough food if all your calories are coming from whole foods. Now, if you're drinking alcohol and you're eating a lot of processed foods that don't have sodium in it somehow, maybe you could design a diet that wouldn't be adequate in sodium, but that's not the type of diets that we're talking about. And in fact, the major risk factor for sodium is excess salt, and that's also not controversial. People know if you get too much salt, you're at significant increased risk for everything from congestive heart failure to hypertension. And about a third of the population are particularly salt sensitive. They hold on to salt really efficiently, and those are typically your hypertensive patients. And since 60% of people are over 60 are hypertensive now, it's a major contributing cause of death and disability. We know those people definitely don't want to be adding sodium to their diet. Also, sodium is a major contributing factor to obesity. And you might say, well, what's ridiculous? How could something with no calories, 0 calories, sodium chloride has no calories, make you fat? And the way it does it, though, is through what's called passive overeating. So if you take an animal and let it eat its fill till it reaches satiety with whatever food you want to put in front of it, say rice, it'll eat a certain amount. Everything else being equal, you salt that rice up, it'll eat more before it reaches satiety. And people say, yeah, because the salt makes it taste better. And that's true. Salt makes it, what tasting better means is that when you eat that, you get more dopamine stimulated in your brain, more dopamine, the neurochemical associated with the pleasure. So, but it's a drug-like effect. It's fooling your brain. Just like sugar is a drug-like effect and oil has a drug-like effect, so does salt. So it doesn't mean salt's not good, and it doesn't mean you don't need salt. There's just, you only need so much. And if you get too much, which is what happens when people eat refined carbohydrate foods with salt added to them, they develop obesity and all the disease of dietary excess. So it's important, if we want to get people to lose weight, not to overuse these salt, oil, and sugar foods. Think about this. Bread is 1,500 calories a pound. If you put coagulated cow pus all over it, butter, it's got a much higher caloric density. But even without the butter, 1,500 calories a pound. People eat bread, they love it. But if you take the salt, the oil, the sugar, and the yeast away, what do you have? It's called matzah, and it's punishment on Passover. Nobody's getting carried away eating matzah. It's a carrier agent for the salt, oil, and sugar. Beef. Take some beef and boil it. Do you like boiled beef? Is that really attractive? No. What you like is using beef as a carrier agent for the salt, oil, and sugar, the sauces, the things that, particularly salt, that adds the flavor, makes it taste good. It stimulates dopamine production in your brain. The same dopamine that's produced by cocaine, alcohol, caffeine, maybe not quite as intensely as cocaine, but it is interesting. Cocaine, that fine white powder, sugar, that fine white powder, salt, that fine white powder. You got to watch out for fine white powders as far as I'm concerned.
All right, we're going to sideline sugar because we both agree on that. Where I am curious, if we're talking about salt and oil in only a whole food perspective, and okay, oil is already not a whole food. If you take an olive and you press it, that's not a whole food. And salt isn't actually a food. Again, no calories. But are we missing the big picture here? Are we talking about ultra-refined processed foods with those three? Because when I think of salt, sugar, and oils, I think of things like crackers and chips and processed foods that are high in carbohydrates. I'm not thinking about, a grass-fed, grass-finished steak with some sea salt on it and then put on the grill, and then some asparagus that's got some olive oil poured over it. Talk about, to me, I think we're missing the bigger picture of processed foods when we talk about those three. And
we agree.
I think they can be included in a whole food, quality food diet and be neutral or health promoting.
Okay, so we agree that most of the sugar, oil, and salt is used with highly processed foods because foods that are highly processed don't taste good. They're just carrier agents for salt, oil, and sugar. If you take process of food, and mostly grains, it doesn't have much appeal. It's matzah without the oil, salt, and sugar and yeast. Well, if you take those highly processed foods, people won't eat them without the sugar, oil, and salt. So the trick is, how can you get as much sugar, oil, and salt into it as possible to make it more appealing? That's why when you go to the fair foods, they'll take those Snicker bars and then deep fry them, do something to increase caloric density even more so that people will like them even more. They make them even tastier. We agree, that's no good. Now you're saying, okay, but if we take something where the carrier agent is healthier, say the asparagus or something, I would argue, first of all, I think for a palate that's neuroadapted, which happens with fasting, where your taste perception to salt, oil, and sugar change, by the way. We've done a study. You can look at taste neuroadaptation study. The palate changes when you stop eating it. It takes about 30 days to neuroadapt to a low-salt diet. On a healthy diet, it takes a few days with fasting. So that asparagus is tastier, steamed asparagus, than when you drown it with olive oil and put a bunch of salt on it. It's just a carrier agent for the addictive chemical substances, the oil and the salt. And it's certainly not healthier. There's no reason to think that we're getting something out of oily, salty asparagus that's healthful, that steamed asparagus, wouldn't be as equally nutritious. It may be more appealing. I'm not disagreeing with that, particularly for a person that's addicted to the stimulation of all oil and sugar. If you talk about beef, you're making my point that beef itself isn't that appealing, but if you put some salt on it and you put some oil on it and make some, get some acrylamides formed with some high temperature char broiling, now it becomes appealing. It also is a health compromising component, not necessarily a health enhancing component. And so We can disagree about, could you get away with it? Sure. Lots of people can be healthy with small amounts of animal food in their diets. They might get away with a certain amount of sodium added to their diet without it compromising their short-term health. But it's not a health promoting necessity. You're saying, can you get away with it? Some people can get away with it. For example, some people can drink alcohol and not become a drunk. But if you're a drunk, that's not you. We don't tell alcoholics just have a little bit. Have really high quality wine. If you buy wine that's more than $50 a bottle, you won't be a drunk anymore. Or if it's a really good beer, the Pilsner beer, that's okay. But the cheap stuff, yeah, we don't want that. We tell alcoholics what? Don't drink. You're addicted to the artificial stimulation of dopamine that comes from those chemicals. You shouldn't drink. Some people can do it. That's not you. If a person is overweight, obese, or has autoimmune disease or cancer, which is mostly my population, I would prefer they not use salt, oil, or sugar. Could they use a little bit? Sure, they do. If you look at our studies, we don't get 100% compliance. And yet they're doing well enough to maintain their optimum weight, their blood pressure. So if you have a patient that's maintaining optimum weight, blood pressure, function, I'm not going to be as upset about it. But to pretend that they're going to get a benefit from doing that, I think that's a tougher argument. It's up to the people making that argument to prove that that's true. I don't believe that that's true, but I could be wrong.
Well, what I like about, say, steak and some asparagus is the lower carbohydrates. And if we're comparing that to, say, a quinoa salad and a sweet potato, and I mean, you would be able to lay it out better than me, but we're naturally going to have more blood sugar variance eating your diet versus a steak with asparagus, with some sea salt there, some oil. And this is going to help with our metabolic health. We're going to have lower swings in blood sugar, lower swings in insulin.
Okay, there's no evidence at all to suggest, though, that a complex carbohydrate-based diet, a whole plant food SOS-free diet, has lower or higher swings. In fact, just the opposite. We've got good data supporting long-term outcome in hypertension, diabetes, autoimmune disease, and cancer. Show me the data that suggests that we would get better results by adding some oil and salt and putting some steak in there. I'll be happy to reconsider our whole dietary program. We're doing what we're doing because the evidence and our experience suggests, particularly for sick people, that's what it takes to actually get them well. Our patients normalize their pressure and get off medication. Show me the evidence that me putting salt in that diet is going to enhance that benefit.
No, but compare a steak to a quinoa salad with some sweet potato. You can't, to me, if you have a steak and you have a CGM on and you compare that to, say, a quinoa salad, again, you can talk about what one of your clients or patients would be eating when they came off of a water-only fast. But if they're having plant-based materials, they're naturally going to have more carbohydrates. So there's going to be more blood sugar swings with that diet. Like, I don't know how you could argue otherwise.
No, the biggest problem is insulin resistance. If you eat a high-fat, high-protein diet, you will have more insulin resistance. That contributes to causing diabetes. Short-term, sure, you'll have better insulin control. You can put people on the carnivore diet. They'll have great glucose control initially because there's no glucose. But they're going to end up with gallbladder disease, colon cancer, and problems down the road. That's what you got to be concerned about. It's not the short-term benefit. You can go on a ketogenic diet, get all kinds of short-term benefit, including fasting, but you don't tell people to fast forever because we know that you can't do that. You're going to end up with problems. Same thing with a high-fat, high-protein diet. Sure, you can get weight loss. You can get blood sugar control short-term. That's not what you're most concerned about. You're concerned about long-term. And what's going to happen to the person on that high-fat, high-protein diet long-term? And where's the data showing that people can eat those diets and sustain long-term health? That doesn't exist as far as I've seen.
But where's the data show otherwise? Are we talking about observational epidemiological data, or do we have any randomized data comparing those two different diets?
Well, I don't think there is good randomized data yet on that because those diets have been, the studies that have been done with the Dead Dr. Atkins diet and the other various versions that have come along have not been very compelling. So short-term, great, long-term, suspect. But again, I'm open to the idea that maybe we can do some good long-term studies and show good outcome. Right now, the only outcomes I've seen long-term that are really compelling are the stuff that we're trying to implement, which is the people like Ornish and McDougall and Campbell, and they're talking about the China study, the long-term studies, which almost all of those are using whole plant food, complex carbohydrates. They're not necessarily what you call low fat, because many of them are 15, 18, 20% of calories from fat. They're all around 10% of calories from protein. But most of the carbohydrate are going to be whole plant food carbohydrate. But you can't pretend that whole plant food carbohydrate is the same thing as refined carbohydrate. We already know that 80 to 90% of carbohydrates are refined carbohydrates. Almost all the data out there that talks about carbohydrates is refined carbohydrates. So I don't see a lot of controversy between what we're saying here in terms of, if you're willing to eat your carbohydrates from whole plant foods, you're going to have a completely different insulin response, et cetera, than you would be if you're eating refined carbohydrates.
That's true. I would agree with that, but it's going to be different than eating the steak and asparagus.
Yeah, in the long run, our patients are able to maintain, regulate blood pressure control, blood sugar control. I've got data to support that. I don't see the data saying that throwing in steak and olive oil is going to make it better. If it is, I'd love to see the data. If your viewers have those studies or that data or that evidence, I'd love to review it. I've looked for it. I haven't been able to find it. So, that may just be the limitations of my own efforts.
The other aspect we got to talk about with a plant-only diet is plant toxins, things like oxalates, lectins, phytates. We could go on and on. So it's not just about what you're getting from nutrition-wise from that food. When you're having animal products in your diet, you're naturally going to take in less of those. So how do you look at those?
Oh, but you won't have the oxalates, but you're going to have PCB, dioxin, pesticide residues. You've got 2 to 1,000 times the concentration of the things that will actually kill you. Now, it's true. All plants have different chemicals in them that can be annoying. And if you're sensitive to those particular proteins, then you want to avoid that particular class of foods. But most patients are able to find, if they can't eat grains, then they can use starchy vegetables. They can use potatoes or sweet potatoes. If they can't use that, they can use, there's other things. There are lots of different plants out there. We can rotate those foods. And also after fasting, a lot of those sensitivities go away. So because they don't have the gut leakage anymore, there's not proteins leaking in that are stimulating the immune system to be a problem. So we're able to manage a lot of those people with hypersensitivity problems, either by modifying the diet, rotating the diet, or eliminating classes of foods in the diet that are a problem. If you're going to talk toxicity, though, animal foods are really hard to defend. Now, you're going to say, okay, what about grass-fed, organically raised with love, that die from natural causes and all that stuff? That's great. That would be less bad. That would be much better. But those animals still live in the same environment that we do. So even if they're not being fed, food grains, antibiotics, ongoing exposure to the environment, they're still biologically concentrating the normal environmental toxins. And that's why when you look at them quantitatively, animal foods are massively higher sources of the toxic products than plant-based foods are. And now you can make the same argument for plants. Well, if they spray chemicals on them, that's true, but they still don't biologically concentrate it as well as the animals do. And it's easier to buy and more affordable to buy a plant-based diet. Why do you think the 3 billion people on the planet that make less than $5 a day, what do they eat? Rice and beans, okay? Why? Because animal foods 10 times cost per calorie. So it's not a diet that would even be amenable to people. That's why it used to be only the kings that got gout and cardiovascular disease, because they're the only ones that could afford to eat the large quantities of animal foods because they're more expensive. And then there's also the moral, ethical, spiritual. People don't want to kill the animals and be mean to the animals. They don't want to destroy the planet with global warming and because of the animal husbandry practices, the economic realities. So there's lots of arguments people make. The question you're bringing up, though, is a good one. Let's look at data and see what the data says about what's the best diet for people to eat to maintain long-term health. I just don't want us to only look at short-term glucose control, but long-term glucose control. And I think we can make a case for a plant-based diet in exclusive whole food diet rather than an animal-based diet to make the best long-term outcome.
The other piece of this we should look at too is what population we're talking about. Somebody who's coming at this, who is going to your clinic, who is one of the 80% who has a chronic disease, and they have a compromised system versus somebody who is just trying to maintain health. Because I would be curious on your thoughts on the evolution of people over, say, the last 200,000 years. Do you think that we've evolved on a plant-only diet? Or do you think that given our modern society and how sick we are, that this is a good alternative for this point in time? I know I'm throwing a lot at you, but do you think that we've evolved on a plant-only diet? And then also, is this diet only advantageous at this point because of how sick we are as a whole?
Well, first of all, no, we didn't evolve on a plant-only diet. We ate whatever we could get our hands on, whenever we could get our hands on it. And that did include animal, maybe more bone marrow than it did meat necessarily earlier on. But nonetheless, animal foods have always been a component in the diet of most human beings. But it probably represented a relatively small percentage of calories for most peoples. So, there was a lot of hunting and gathering, but gathering may have been a more significant source, at least for most people. But you also have to remember, that didn't necessarily mean that diet let people live a long and healthy life. The Munich brewery workers, were used as a base to determine how much protein we should eat, ate 135 grams of protein. But they died in their 40s from cardiovascular disease. So that was hardly what we consider, desirable long-term health. There's lots of people that have eaten high animal foods diet, but they tend not to have long lives. And if the percentage of calories represents too high a percentage of calories in their diet, witness the kings. So I think that we can make an argument that, yes, people are designed to and capable of eating animal foods. It's just in our modern environment, it appears from my viewpoint, the less the better. So if they are included, clearly you want some that are less toxic, and you don't want too high a percentage of calories to be derived. Can I make the argument that 0 is better than a very small amount? No. I don't have any data that says, the person that's 100% vegan does better than the person that occasionally has a small bit of this or that. In fact, there's a danger to being vegan. And that's the severe headaches that can occur when your halo's too tight.
You talked about B12 earlier. We know there's certain nutrients that we only get from animals. The argument in the plant-based world is that we can convert things like ALA to DHA, EPA, or beta-carotene to vitamin A. Again, B12. We know that with that diet of plants only, we need to supplement to make sure we're getting the full spectrum of nutrition. So right there tells me that this diet isn't ideal if we have to supplement
let's be clear, though. Let's be clear. B12 doesn't come from animals. It comes from bacteria. It happens to be that animals are a great source of bacteria because there's a lot of feces contaminated into ground meat. If you separate ground meat into meat cells and fecal cells, there's a nice pile of feces. So you're going to get plenty of B12 if you eat meat, I agree. That is the one and only nutrient that we have to routinely supplement. And it's not because we're not eating animal foods. It's because we have hygiene. We're washing and peeling because we don't want worms and parasites. So if you go to cultures that are not doing Western hygiene, they don't have B12 deficiency, even if they're religious vegans. But it's our washing and peeling, and that's good because you don't want to have to deworm your kids and have all kinds of challenges with infections and problems. So we do supplement B12 because of bacterial contamination lacking, not just because you didn't eat animal foods. It just happens to be animals are one source of that bacterial contamination. Vitamin D is from the sun. If you don't get out in the sun, we're going to supplement D. But the best way is to make it naturally. There are other nutrients that plants don't necessarily have: iodine, zinc, etc., selenium. But these are generally provided in the diet without supplementation, unless you live in an isolated place like, say, Minnesota, where there's no iodine in the soil. So you either supplement the soil or you supplement the diet. But that's not an argument for saying you can't healthily eat a plant-based diet. So I don't think that's a sign that it's not a healthy or health-promoting diet. And if you were going to make that argument, though, you wouldn't need very much quantity of these other food factors to meet those micronutrient needs. And so it wouldn't be you don't have to eat 50% of your calories from dead, decaying flesh in order to get enough, B12 or anything else. So again, the question is proportionality. I wouldn't argue that the only way to be healthy is to eat a vegan diet. I'm just saying in the modern world, that may be the most practical solution to avoid the problems of food contamination, biological concentration, and also to address the moral, ethical, and spiritual complications, in terms of environmental impact and social impact, et cetera. If people don't want to do that, that's fine. When I go to vegan conferences and I speak to the vegans, I often say, as bad as meat is in terms of health issues, some of this processed vegan crap is even worse. You might be better off eating the meat than some of this processed vegan food because it's full of salt, oil, and sugar. And so at least meat is a whole natural food. It is a whole food. It is not a highly processed food, but the way meat is served is often in a highly processed format. Again, it's the salt, oil, and sugar that are added to it that make it palatable to people.
I think the other aspect we need to bring into this, just to round out this part of the conversation, is having enough to not have a nutrient deficiency versus optimal. Whether we're talking about salt, iodine, any nutrient. We can't go by what the government's telling us and assume that is optimal for our health. So some of your arguments there, it sounds like we're getting enough. But to me, enough based on what and who's telling us enough?
Well, a lot of what you need is dependent on what you eat. So the higher, for example, the higher your protein intake might affect how much, for example, you need of zinc or other nutrients. So if you're on a high phytate diet, for example, it inhibits wheat absorption or zinc absorption. So you'd need a higher amount of zinc than you would if you were on a low phytate diet. So people eating a lot of refined carbohydrates in the form of bread products and stuff might need more zinc than the person that doesn't eat those. So it's not simple to just say this is the absolute standard. But most diseases that you see are not deficiency diseases. Whether it's in vegans or meat eaters, it's mostly conditions of excess. All the stuff we talked about earlier, heart disease, cancer, diabetes, autoimmune disease, these are not deficiency diseases. These are diseases of dietary excess, mostly macronutrient excesses, excess fat, excess protein, excess sodium, excess, not deficiency. And so treating them as deficiency diseases by giving you vitamin pills or potions or stuff is not effective. There's no data supporting that. What's effective is getting rid of the dietary excess. Now, I'm not arguing, though, there aren't diseases that might be associated with suboptimum intake of micronutrients. And for those people, you better make sure that the diet, whatever the diet is, has you covered. And in fact, we break that down in one of our books called the Health Promoting Cookbook. We break down the diet not just by protein, but amino acid by amino acid. We break it down by micronutrients and show what does the actual diet we're recommending have. And you can look at, and granted, you're comparing it to the standard recommendations, which are up to debate. But there is no micronutrient problem if the majority of calories are coming from these micronutrient-rich foods. In fact, it's quite the opposite, because it's not just the quantity of there, but how it works. And that's where, again, I go back to Dr. Campbell's book, Whole. For example, 50 milligrams of vitamin C supplemented can have a tenfold difference of 50 milligrams from the diet. So the biological impact of it is impacted. So it's not just, as you pointed out, quantitative, but it's also qualitative. So if you're going to make the argument that we have to have animal foods, then we need to see evidence that the micronutrients or macronutrients in those foods are not being adequately provided by the whole plant food diet. If that were the case, I wouldn't expect to see my patients that have been adhering to this diet for 40 years to be outliving everybody they know, particularly their meat eater friends.
No, I can't deny what you're doing is working for the population you're working with. And as a whole, I generally agree with most of this conversation. And this last part, we're going to have to agree to disagree on the diet piece.
We can agree that we need more research.
100%. And there's so many layers to this. When the research is done, we need the quality. And I know you're going to poo-poo that word when it comes to animal products, but we can't compare CAFO beef to, we need to have the pristine, healthy animals and use that as our source for these studies.
Let me ask you this, though. What percentage of the animal food that's served in the United States right now do you think is coming from the high quality where they really do things carefully? And what percentage of it is coming from it's almost infinitesimally small. So it's, 99% at least is coming from commercially raised, and that's what people are eating. When they go to McDonald's, when they go to the fast food restaurant, they're not getting, free-range fresh salmon. They're getting fish farm salmon. They're not getting the type of beef where the family farmer provides loving care and raises them on grass and whatever. That's not the reality. So even if that's true, that special versions of beef or special versions of fish or whatever might have some additional benefits, that doesn't really address the bulk of the problem that we have in society today, which is that animal foods are a major contributing cause of death and disability amongst the people that are out there. And maybe it's because it's the wrong kind of animal food, but nonetheless, that's what mostly people are getting.
Everything is so entangled. And then again, when we're talking about having the McDonald's burger, there's the soda, there's the French fries, there's the seed oils that the French fries are being cooked in. So it's
right.
I don't think we're ever going to have a totally clear answer and clean research. I don't know how we would be able to isolate two groups of people and do it long enough term that we're getting data that we could.
Well,
Meaningfully
wouldn't you be
base
able to
our
take some
diets off
people
of.
and give them a diet with the really clean beef and the really clean fish, and then just compare them how they do long term to the people that are, say, eating the plant based diet? I think that is a study that could be done. You know,
But there's
you just
still
have to. But
like,
it has.
then are those people that are having the beef, drinking beers at night and smoking. Like, there's so many variables. All I'm saying is that this does get messy. This does get gray. And I think we're going to have to accept that as being a piece of this. And not that we don't do the science and we can't do good science, but I don't think it's ever going to be totally clean, because a lot of times when we're having, again, these lower quality meats, there's all these other variables. Is alcohol involved? Are we exercising? Are we sleeping? Like, it's so multifactorial in so many pieces. But all I know is, given what we talked about within the diet conversation there, I feel added insurance, including animal products, in my diet at this point until I'm convinced otherwise. And I personally only eat quality animal products. And I think 95% of what we talked about, though, we can agree upon. And a lot of interesting thought experiments are coming about throughout this dialogue. So I appreciate it. And
Well, what I suggest we do is let's compare your high quality modification diet, and let's get a bunch of people that are doing that, and let's really track their outcome, and then we can compare that to people that are doing a slightly different version of it. We may find that it doesn't make that much difference. They all live well and do well. That may be the end conclusion. But if you compare that to the 35 or the other people that are eating conventionally raised animal foods, I can guarantee you it's not going to look pretty. We already have data on that. You've got millions of people testing out that experiment, and we know what happens. They're dying slow and painful deaths. They're spending 20 years debilitated. They're ending up in nursing homes. That's not, and again, whether it's the refined carbohydrate, it's the animal, I don't know which component is the dominant component. But what would be nice is to see, can we show that there's modifications of the diet different than what I'm suggesting that work as well or better? And I think that is testable. It's just, you got to have people that are willing to get a population of people willing to do it right, not complicate it by other health compromising habits.
And if we do find out that people can include some of these other foods that I'm talking about, and the results are the same or even better, then we can get greater compliance, because naturally people are going to buy into what I'm saying. It's a lot easier to do than to eliminate all that and to eat,
of course,
without including salt, oil, and sugar. Again, right. I don't even want to bring sugar in because I'm anti that as well. But
so the thing is, we don't recommend.
Then we can increase the population health as a whole in such a greater way if we find out that this diet that I'm talking about, again, is equal or even better.
I mean, I had this argument with Dr. McDougall as well, because he's arguing that, look, to save the planet, we have to get people eating a vegetarian diet, because he believes that animal husbandry is largely responsible for global warming, more so than the internal combustion engine. And so he said, if you do what we recommend, which is the SOS-free, it's harder to do. You can't get the compliance. And so we're not going to get as many people converting across. I don't disagree with him. If you want to save the planet, it'd be nice to get everybody that you can doing what it is you think that's going to be helpful. But that's not my goal. I'm not the person that's trying to save the planet. I just want my patients to live a long and healthy life, not be debilitated, live until they die, and prove I'm right and everybody else is wrong. That's really what the driving force is. So I don't say that our approach is the best way to save the planet. I just say I think this is the way that we can get people to live and avoid debility. If we can do it better, I'm all for that. And so we'll change our recommendations if we can get compelling evidence that makes the argument that we're not giving the optimum recommendations to people. And so, that's why I think we do need additional research to kind of fine tune those things. But what you and I have both talked about today largely is the same message. Eating lots of whole foods, maybe they include animal foods, maybe they don't, minimizing, getting rid of the sugar. If you're going to use processed foods like oil and salt, certainly there's some limits to how much of that you're going to recommend people do. We don't eat the amount of sodium, for example, that people are eating in conventional diets is associated with heart disease and all that kind of stuff. And everybody should exercise, everybody should sleep, and everybody should learn to manage their stress more effectively. And if they do that, they're likely to live a long and healthy life, and everybody will be a lot better off.
Alan, I know you got to go, but we'll end on this. Somebody like me who is consuming a lower carb diet, omnivore, high quality, everything's high quality. I want to do a water fast and come to your clinic. Is there room for somebody like me there? And how do things differ when you're working with somebody who isn't buying into the diet piece that you guys are recommending?
So the preparation is still the same. 48 hours before fasting, you don't want to be using animal foods just because they're going to be more concentrated in the gut. And then when you come off the fast, we don't start with steak and olive oil. So we're going to start off like we would fruit and vegetable juices and bring it in. But then what you do after that, all we're going to ask you to do is whatever diet you're eating, make sure you're maintaining optimum weight, your blood values look good, the things we know as markers are good. And if you can do that with a more flexible diet, I agree with you. If we could offer a more flexible diet that would get the same or better results, that would be fabulous. It would make it so much easier to convince people to try making this transition. What we're doing is not easy. It's the most difficult thing that you could ask them to do. Unfortunately, that's kind of what we've seen the results with. So we've got to, I'm open to the research, though. I think it'd be very interesting to compare and contrast.
Me too. And I want to add, too, I'm not doing what I do because it's easy. I've actually come from the vegan world, and I've done that diet for a number of years, and I've tested diets across the spectrum. And what I'm eating now isn't out of convenience at all. It's about what I think is most health promoting. So I just think it's important to add that, because for some people, easy might be part of the equation. But for me, I'm lucky enough to be in a position where that's not what I factor in when I'm choosing what to eat.
Understood.
All right. Really appreciate this discussion. Very healthy debate, banter between the two of us. I appreciate you being open to doing that. And like you said, I think we agree on most of this. We're going to link up the new book, Can Fasting Save Your Life? We're going to link up your website, social media. Alan, this has been a real pleasure. Thank you.
Excellent. Thanks for helping us get the word out.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
Insulin's pushing harder, it's pushing harder, it's pushing harder. But at some point, it reaches its limit. And then, no matter how hard insulin pushes, you can't shove any more glucose into that cell. And therefore, that's when the glucose